such a pleasure to be here, and I have to explain the kosher butcher thing. I'm sorry, but we'll start with that. I'll explain it in a second. First, let me say it's such an honor to be here as the Frank Black lecturer, and incredibly humbling in light of his career and the work of the Prasad family in terms of 3TC. I did my training at NYU in New York City in the mid-'80s, when 1 out of 5 patients that we cared for was essentially dying of AIDS. And the difference that antiretrovirals has made to a generation, and now a second generation of people suffering with that disease, is just extraordinary. So I'm doubly humbled and thrilled to be here with a lot of colleagues and friends from BIP and the CDC and Yale. And that my dad was not a kosher butcher. Sorry about that, but my dad actually went to Yale, so it's really exciting to be here. My dad was in the class of 45W, which was the class that did accelerated time because there was a war on, and then he went and served in the Navy in the Pacific. But he has very brief but fond memories of his time here. And when my brother came here for graduate school, my dad was just thrilled to get back on campus and get to see Pearson College, I guess is the place that he was at. So what I wanted to do, actually I didn't tell you the kosher butcher story, sorry about that one. So, oh, here we go, this is all I needed. My grandfather actually had a small store. My grandparents ran a small store in Marlington, West Virginia. They were the only Jews in the town, and so my dad learned how to become a kosher butcher in order to prepare food correctly. So then the name Shukit comes from the Hebrew shochet, which is the kosher butcher, or as we used to say, the ritual killer of chickens. When I became the director of the National Center for Immunization and Respiratory Diseases, and bird flu was under my authority, which the intervention for bird flu in the birds is to kill all the chickens. My mom thought it was destiny. So what I wanted to do today was talk about public health versus the viruses, which I'm standing in front of the slides for you, sorry about that, which is a matchup for the century. And you know, it's a real question who's going to win in this century, and I wanted to do a little bit of review of recent history to talk about how we as a public health profession, you as students or faculty, and we as a community take on these pesky viruses. So I wanted to start going back to some of the great matchups of history with the of course, classic matchup between David and Goliath, where size did not matter, and when it comes to viruses, that is probably also the case. If we look at last century, there is one clear victory for public health against the viruses. Smallpox is the only human disease that has been eradicated from the planet through intentional efforts, through an enormous public health effort and a very strategic use of vaccine. But if we look at last century, public health did not always win, and perhaps the most telling of those matchups came in 1918. We're celebrating or mourning the 100 years since this terrible event, but the global influenza pandemic of 1918 killed perhaps more than 50 million people worldwide, and had this incredible effect on life expectancy, which you can see in the slide. It reversed life expectancy by 12 years. The past 2 years, we've been making a big deal out of the reversal in life expectancy by less than 1 year. So this was an enormous impact on young, healthy people, and one that completely overwhelmed healthcare and society for quite a while. So I want to talk about what does it take to overcome the viruses, and when we think about the great matchups, strength can be important. Of course, we look at Muhammad Ali, or I think he was Cassius Clay in this picture. He was the greatest. Well, I think when we think about strength and the greatest of viruses, influenza really has perhaps an edge. I was thinking of the students and what grade you must have been in 2009. I don't know how many of you got sick in 2009 with the so-called swine flu. See a few heads nodding. I know folks got sent home from camp. Some of the schools were closed temporarily. It was extremely disruptive. But in the course of 1 week, this is what happened. On a Tuesday, CDC reported on 2 children in Southern California who were infected with influenza that was a totally new strain. We called it a swine influenza at that point, but it was a strain that came from pigs and that caused mild illness, and the 2 people were better. By Thursday, okay, good. So now the people in the back can start laughing at my jokes. That's better? Yeah, okay, sorry about that. All right. Didn't put it on the checklist when I submitted to come here. So on a Tuesday, we knew of 2 cases. We issued this early release in the MMWR, and by Thursday, we had 5 more cases of this novel influenza virus, never been seen in people before. Everybody was fine. The 7 cases were just fine, but we did a press conference. Half of the reporters at the press conference wanted to know why were we holding a press conference for 7 people who had mild illness and were all better. And the other half of the reporters who were familiar with the work we'd been doing to prepare for a pandemic wanted to know, is it the end of the world? That night, we learned that investigators in Canada had been testing specimens from Mexico, from people who had died from respiratory illness in Mexico. And they had the exact same genetic pattern as the 7 people in the United States. We had posted the genetic sequence of this new strain. And the following day, on Friday, April 24th actually, we learned that a school in Queens, New York had hundreds of students out sick with what turned out to be the very same virus acquired when they were traveling to Mexico on spring break. So in the course of a week, we went from hardly anything to, a new virus that has the ability to become a pandemic. So what is a pandemic of influenza? A pandemic happens when you have a new virus that there isn't population immunity for, and when it is capable of causing disease in people, not just a strain that's out there, and that it is capable of efficient person-to-person transmission, which is kind of a feature of seasonal influenza. The 2009 H1N1 influenza strain had genetic components from birds, from pigs, and from people. It hadn't caused disease in people until 2009, and then it quickly caused disease in people around the country and around the world. Although it was an H1N1 influenza virus, it was very, very different from the seasonal influenza viruses that were targeted by our seasonal flu vaccine. And so we needed to make up a vaccine exclusively for this pandemic strain. And in the fall of 2009, some of you, if you were one of 80 million Americans, would have gotten vaccinated with this monovalent or pandemic flu vaccine, probably in addition to the regular seasonal flu vaccine that you had already gotten. We were lucky in 2009 that the pandemic strain seemed to relatively spare the elderly. So although we worked very hard as a public health community and responded very rapidly, even though vaccine became available quite late, we were lucky that we had fewer total deaths that year than in seasonal flu because we didn't have large numbers of the elderly dying. But we had large numbers of young adults and middle-aged folks getting influenza and some of them being hospitalized and dying. Now that was, almost 10 years ago now. What is probably more on your mind is this year and this seasonal influenza, where we are probably losing the battle with the virus this year. It's an H3N2 dominant strain this year, and H3N2 influenza seasons are much more severe than the ones where H1N1 or B strains tend to dominate. Here you are in the middle of Connecticut as part of the Emerging Infectious Disease Program, and the EIP across multiple states tracks influenza hospitalizations. So this graph at the bottom left of the slide shows this season in red, hospitalizations per 100,000 population compared to all the seasons back to 2010 when we started tracking this way. And you can see that already this far into the season, we are breaking records for hospitalizations. So it's a bad year in terms of H3 and 2. In the map, you can see that we're having intense disease in most states at the same time. That's led to antiviral spot shortages, and it's led to a lot of strain on the healthcare system. So influenza is difficult when we have pandemics. It's difficult even just with seasonal flu. The third type of influenza is avian influenza that we have to be worried about. And we're also very focused on something called H7N9 avian or bird influenza in China. This emerged totally new in 2013 and started to be better controlled in each fall wave of disease as the Chinese really improved on the practices around selling birds, cleaning up what were live bird markets. And so once we got into the fourth wave of H7N9, it looked like things were getting better. And then we had this very difficult fifth wave of avian influenza caused by the H7N9 virus. Well, what happened in that fifth wave, which was the 2016-17 year, what happened there was that the virus changed. It mutated subtly, and it became capable of causing disease in birds that was fatal, high pathogenic avian influenza in birds. It was already 40% fatal for people, and it spread widely throughout China. Because it started to kill the birds, in China they started to take it more seriously. It was starting to cut into the ability to, into their poultry sector and their economics. And the Chinese developed a vaccine to immunize chickens. Going back to my ancestry here, they have vaccinated billions of chickens against H7N9. And in 2017-18, in the current season, there have only been 2 or 3 cases of H7N9. So it seems like their poultry vaccination is having a really good impact. But what we saw when they did the same thing against H5 avian influenza many years ago, it can only be sometimes 2 or 3 years of impact before this virus mutates and figures out ways to evade the immune pressure. So keep your eye on China and Asia and the H7N9 story as a reminder that influenza has a lot of tricks, and more than just being the greatest, we need to really stay ahead of this virus. So another issue that's very important in a matchup is speed. And when it comes to tackling the viruses, speed is not always on our side. This is a map of air travel in a 24-hour period. And you can see that it is possible to get pretty much from anywhere to anywhere else within 24 to 36 hours. And that means that it is also possible to have a disease spread from anywhere to any place else within that same time period. I think many of you are used to traveling around the world and enjoying that freedom, but it's amazing how quickly infectious diseases can spread and the challenges it is for public health to keep up with them. I think I was talking this morning to the pulmonologist in the room, who I can't find now. Oh, there you are, okay. So I sat next to this pulmonologist this morning, and I was a little worried, and I'm going to tell you why. There was a pulmonologist in Guangdong, China, who was caring for people who had respiratory illness on the wards in southern China. And then he went to visit Hong Kong. And he stayed at, it's always a bad sign in epidemiology when your name is initialized. So he stayed at the Metropole Hotel, which is immortalized as Hotel M in this photo. But the Metropole Hotel housed this gentleman who unfortunately stayed in room 911. I can tell you that started a lot of rumors, but people who stayed at the same hotel on the same floor when he was there developed an illness quite similar to his and took that illness back to their own countries. So outbreaks of what we now call SARS, the severe acute respiratory syndrome, essentially spread from a hospital ward in southern China to a hotel in Hong Kong, to Vietnam, to many hospitals in Hong Kong, to Toronto, to Singapore, and on and on. And if any of you saw the movie Contagion, the way things spread around the world in contagion was very much modeled on the SARS epidemic. It was extremely challenging. It was a respiratory illness that had a high fatality rate and that particularly caused problems for healthcare workers who were caring for sick people and then developed the disease themselves. We did not have a vaccine. We did not have drugs. Initially, we didn't have diagnostic tests. But collectively, public health was able to stop the spread of SARS through ancient methods: active surveillance, contact tracing, isolating people who were ill, infection control, and quarantining people who had been exposed but were asymptomatic and monitoring them to see if they became ill. One of the big problems with SARS was the initial lack of transparency on the part of the Chinese government, which meant that disease spread widely before there was general recognition it was happening. And an outcome of the SARS epidemic was something called an update of the International Health Regulation Framework, where countries around the world pretty much resolved to be transparent about their epidemics, report promptly, because everybody would benefit by knowing about the problems in everyone else's backyards. That IHR framework has become really, really important in this decade as well. Talking about speed and going back to the H1N1 epidemic, the pandemic was recognized here in the United States, although it emerged in Mexico. And within just 6 weeks, based on distribution of these diagnostic tests around the world so that we could recognize this new strain, it was detected in 122 other countries. Influenza can spread quickly. You can have no symptoms. Tests are not going to be that specific. And so this is the kind of slide that helps explain why closing borders will not have an effect on the spread of pandemic influenza, that we really need other approaches. Now, another tool that's quite helpful in a matchup is SMARTS. And if you're talking about chess, it may be that SMARTS is a question of exploiting your opponent's vulnerabilities. One of the sadder stories in the virus public health matchup in this century is the story of Ebola in West Africa in 2014-15. And this was really a question of the virus exploiting our vulnerabilities. It's not a coincidence that the outbreaks were so bad in Sierra Leone, Liberia, and Guinea. These were countries that, between civil war and isolation, had substantially limited public health capacity, very little investment from their governments or from others in strengthening their frontline ability to detect, respond, and prevent epidemics. The virus in these contexts really took off and was extremely difficult to counter. We had been dealing with Ebola outbreaks for 40 years. I was at a meeting in Geneva where people were talking about, this is new, we don't have a vaccine yet, and the ambassador from Sierra Leone said, you've had this disease for 40 years, how come you don't have a vaccine yet? This isn't a new disease, why don't you already have one? They were quite concerned. But the West Africa outbreak caused 10 times more cases than 40 years worth of outbreaks. And it really surprised the public health community as well as the experts in Ebola, because people didn't think Ebola epidemics could get that bad. But what this virus did in 2014 was get into the urban, densely populated capital cities of Sierra Leone, Guinea, and Liberia, where it was extremely difficult to stop. So in all, there were about 28,000 cases and over 11,000 deaths from Ebola, and there were hundreds of healthcare workers who died in a region that had very few of healthcare workers to start with. But one of the things that we don't say enough is what might have been. It was bad, but it could have been so much worse. There was modeling done in the fall of 2014 that tracked the exponential increase in cases and that said if we do not scale up intervention, we could have like 100,000 cases when it got into Nigeria, if we do not respond quickly, we could have this virus endemic throughout the continent of Africa and perhaps spreading to Indonesia and other large places of travel routes with Nigeria. But the community in countries and the global community did surge, and interventions finally did increase. And this depressing exponential curve was turned around. So as it rose quickly, it actually also fell quickly once scale up of treatment, isolation, contact tracing, and other public health tools was made. One of the unique features of the 2014-15 epidemic was that vaccines that had not really been given to people got into the field during the midst of the epidemic. This was the first time investigational vaccines at a very early stage were used large scale in trying to address the epidemic. But as quickly as the trial by NIH was launched in Liberia, or the trial by WHO was launched in Guinea, or the trial that CDC was part of was launched in Sierra Leone, you can see that the disease was already under much better control by the time the vaccine trials were launched. A great result was the Guinea trial, which showed 100% effectiveness in a 3-week short-term period. And the companies involved with these vaccines are trying to get them through the licensure process now. But what we learned was that even at this faster pace of research, it just was not fast enough. And so whether it's research of treatments or research of vaccines, the research community needed to find ways to be able to work much more quickly with local communities and countries in the face of epidemics. So the World Health Organization has developed this blueprint for action to prevent epidemics, and a new organization, CEPI, a Coalition of Epidemic Preparedness and Innovation, I think is what they're called, has formed to try to expedite development of some of these vaccines against epidemic-prone diseases. So we're in better shape the next time one of these tragic outbreaks occurs. So I want to talk about another tool that is important in that great matchup against public health and the viruses. And this is the unexpected. So it's very important with viruses and with public health to think about the unexpected and be ready for it. A longer term way to think about this is that wolf in sheep's clothing. So at a school like Yale, with the history of the incredible breakthroughs in vector-borne disease work that this school has contributed to, I want to talk about mosquitoes. They are a very old foe, but recently have acquired new ammo. This is a photo of a mosquito, as you can tell, with the photographer's blood slowly being absorbed. But the Aedes aegypti mosquito is the vector for dengue. It's the vector for yellow fever. It's a vector that we have enormous challenges with. And now it's the vector for Zika virus. As some of you who work in Brazil know much better than I do, an outbreak of what was initially thought to be either either dengue or chikungunya that occurred in the spring of 2015 was tested and revealed to be the Zika virus, something we've known about. It had caused an outbreak in 2007 in the Pacific, but it caused a febrile disease outbreak in Brazil in the spring. Astute clinicians in the fall of 2015 noticed that there were babies being born with microcephaly, a devastating birth defect, that were occurring in the same areas that had had this febrile outbreak 6 or so months before. Initially, it was complex to show that the one had anything to do with the other. The principles of causation that you epidemiologists study don't work so perfectly for teratogens. But eventually, the evidence amounted to essentially prove that Zika virus could cause microcephaly and other brain damage when mothers were exposed to the virus through a mosquito bite in pregnancy, and babies could get one of a number of devastating birth defects. The full clinical spectrum is continuing to be described, but we think about this now as congenital Zika syndrome, not just as microcephaly, the way we think about congenital rubella syndrome. And it really had been 50 years since there had been a new infectious disease cause identified for birth defects. The war against Zika required new countermeasures. You know, we're used to isolation and contact tracing as important tools in some of these viral outbreaks. Well, they really weren't going to be the right tools for a vector-borne disease epidemic. Controlling the vector was not easy. It is not easy. Some of you are studying new ways to do this, but Aedes aegypti are particularly challenging mosquitoes. Identifying services for pregnant women and families is not a usual part of an epidemic response, but it was really important in the hard-hit areas around the world, including in the territories in Puerto Rico. But a new use of a countermeasure was employed during the Zika epidemic. It turns out in Puerto Rico, 2 out of 3 pregnancies are unplanned, and the access to highly effective reversible contraception was quite limited. So one of the requests in the midst of the Zika outbreak was to improve access to medically proven, voluntary, effective reversible contraception. And a partnership developed called ZCAN, the Zika Contraception Access Network, that helped get tens of thousands of women in Puerto Rico access to contraception during the midst of the Zika outbreak. This was just reported last month in the Lancet Public Health, funded through the CDC Foundation and a lot of private donors. I think this really helped train a generation of clinicians and develop awareness among a generation of women about options that they had. The other initiative that I think will be long-lasting is what we call a local health department initiative. Many local health departments are really good at responding to acute infectious disease issues, and many clinical groups are very good at dealing with maternal and child health issues, but that acute epidemiologic linkage with maternal and child health or birth defects work has not really been a tradition. So in a number of these local health departments, partnerships have developed and placement of staff has been done to help connect women with needs with the clinicians that can help them and the surveillance on needs that exist. So we know that, for instance, in Texas, local transmission was detected basically because there was a new public health staff person in the health department meeting with people, encouraging testing, who found that some of the spread was not coming from Mexico, but was actually here in Texas. So, you know, the numbers on Zika are still coming out. When we reported last April, we had 1,000 pregnant women who had completed pregnancies following exposure to Zika infection. And we saw that up to 15% who had confirmed Zika infection in the first trimester delivered babies with birth defects. Right now, we have about 7,000 women who were infected with Zika during their pregnancies who have delivered or are delivering and whose children are being monitored, because we don't know yet whether babies who are born healthy may develop developmental issues or other neurologic complications because of that viral exposure in utero. These few epidemics that I've talked about have been really challenging for the public health community, and particularly for us at CDC. The size of these responses that have lasted 1 to 2 to almost 3 years have required thousands of CDC staff to assist. We deployed almost 2,000 people to West Africa to help with the Ebola epidemic there, in addition to deployment to quarantine stations and to help in local areas. So where are we going to get the troops to fight these viruses in these matchups? This is where training becomes very important. And training for that big event, for the next matchup of the century, is something we take very seriously at CDC. And meeting with your staff this morning, I know how important it is here at Yale. I want to talk briefly about the Epidemic Intelligence Service. That EIS, also called the Disease Detectives, and for the Contagion fans, Kate Winslet played one of us. I did get to meet her, it's true. But you know, this is a precious training program that really provides hands-on on-the-job training for epidemiologists to help us provide that front line of outbreak response. It's not just a successful model here in the US, but it was the basis for what we call the field epidemiology training programs. These are programs that have been around in a number of countries around the world. I think some of you have probably collaborated with them or worked with them. Now in more than 65 countries, again, a 2-year training program. With the global health security investments that we got, we were able to introduce a frontline field epidemiology training program that instead of being a 2-year, highly mentored program meant to sort of build the leadership level in countries, we have a 3-month frontline training program that has now trained thousands of additional staff to go to districts and to be that frontline epidemiologist in the communities where they live. We hope to be able to continue that kind of work in the future. There are a lot of other training programs that CDC has, and I wanted to just highlight this website, the cdc.gov/fellowships. We have a laboratory leadership service now modeled after the EIS, but for laboratory investigators, trying to help create that elite service that's going to be the laboratory leadership of the future for public health, and then a number of other opportunities there. So I think another tool that's very important in our matchups is that home field advantage. I think that's your logo, right? Okay. So I wasn't sure. They had some other team there. I said, you got to get another team for it. I have to just say, my brother has. You guys have you seen the kale? He has. It's like I almost wore it today. So. This is the point in the talk where I regret that I signed that this was okay to webcast. I'm getting really nervous about what I'm going to say when we get to the questions. Okay, so I talk about this home field advantage for a very important point. I think that connection with the community, if you take one thing away from my talk, my ramblings and my stories, it is that to truly tackle viruses and other public health threats, we need to work with the communities that are affected. So there are a couple different ways to work with people, and I want to just mention 2 of them. You know, I have inadvertently found myself as a spokesperson in a number of public health emergency responses, and was very, very grateful that I had been trained in what's called risk communication. If you offer such a course at this school, please take it. It is a really good skill set to have, whether you work in the lab or in the field, whether you work in infectious disease or something else. But it turns out that when you're in a crisis, information is understood differently. We're usually concerned before we are processing analytically. And so at CDC, we try to train people. We have a mantra for our own public messaging that we want to be first, but we also want to be right, and we want to be credible. It's very difficult to do all 3 things at the same time. You want to wait and not go out there till you know what's going on, but if you wait too long, somebody else will go out there with information that's wrong. You want to, and when you go out there with bad information, you instantly lose your credibility. But it turns out that one of the things that's the most important to credibility in crisis communication is how you communicate, not what you say. And one of the most important aspects is expressing empathy. As scientists and public health experts, you, particularly younger folks, may feel like I've got to leave my humanity behind and be a professional, wear my white coat, or look really official. But actually expressing empathy does a lot to give you credibility. It's not enough to express empathy. You want to also have content behind that. And one thing that's very helpful is to promote action. People are concerned, but they're not panicking. They want to know what's going on, and they'll trust you if you say you don't know what's going on. But you want to say what you're doing to find out, but you also want to give people things to do. So you've heard us say, wash your hands, cover your cough, stay home when you're sick. Those are good things to do, but they're also things that put you in charge and give you a role in addressing the concern that you have. as a communicator or as a researcher or as a public health person, showing respect is just number one. My first visit to Sierra Leone to talk about a vaccine trial against Ebola, the person who became our principal investigator there said to me, I just have two rules, transparency and mutual respect. And I said, those are my two rules too. And he just was fantastic, and we had a really good partnership. But the idea that how you communicate and what you follow through with are both very important. The issue of tapping into the community in Sierra Leone, in Liberia, in Guinea, it was really when the communities got engaged in the response that the epidemic turned. There was a Western area surge in Sierra Leone. Public health was going door to door, but they didn't start by going door to door. They started by meeting with the neighborhood leaders and the community about what was going to be important. How should we do this? It's your community. I just can't tell you how important that is. And I know in the audience there's folks who worked on HIV for decades, who worked on some of the most difficult vector-borne diseases. Working with our communities is always the right way to go. Okay, this is a school of public health. This is an academic institution. You have to keep score. If it's important, you have to measure. If you're not measuring, you're going to have no idea how you're doing. And keeping score or measuring has been vital to the biggest and most difficult public health issues. I want to mention something you may not have heard about. The Global Health Security Agenda is an effort to get every country of the world to have the capacity to find, stop, and prevent epidemics. And joint external evaluations, or JEEs, are being promoted to help identify a scorecard, to have an independent, transparent, objective team rigorously assess the capacities that are needed for public health and provide that to the country, not just for the country's own planning, but for the partners of the international community or donors to help plug in the gaps, to help say, we don't all need to give money for that hospital. There's actually frontline worker gaps, or there's lab gaps, or there's, biosecurity gaps. So these JEEs have now been done in almost 70 countries, and the intent is that they're followed by national action plans. And so this is really how we hope to keep score with the global health capacity that really needs to be built. Tracking or measurement has been really important in the polio eradication effort. It's required new methods. Right now, we've added on environmental surveillance. Testing sewage in Egypt was how they figured out that they finally got polio out of Egypt. And then really monitoring the quality of campaigns. When you're vaccinating billions of kids a year, you really need to know who you're reaching and whether the effort is working. But based on this really incredible effort in tracking, as well as in implementing, we really are on the verge of eradicating polio now. Smallpox was the only virus we got rid of last century, but we are literally that close to eradicating polio. It's less than 25 cases this past year, whereas when I got to CDC, there were 1,000 cases a day. So we're really close, but as usual, the virus is exploiting our vulnerabilities. Where is polio still spreading? The border of Afghanistan and Pakistan. The place before that was northern Nigeria, where the Boko Haram were active. So the hardest places are where we still haven't reached every child. But we're going to get there, and probably pretty soon. So what do you need to face, you especially in the school who are going to be the next generation tackling these viruses throughout this century? There's some really daunting forces. Something that's global becomes local right away, and without local buy-in, we really can't do anything to tackle these concerns. The interface between humans and animals is ever closer. The way that we raise food, the way that the places we live put us in closer and closer contact with very diverse species. We have to deal with a lot of real, huge natural threats, but there are also man-made threats. And some of you helped respond to anthrax, even including here in Connecticut. So we know that those are not just hypothetical, but that man-made threats occur. And I think as many catastrophes as I've personally had to go through, as many things that you've had to see on the news, it is just almost instant that the public and the policymaker concern turns from this being the most important thing to something that we're complacent about. And that just doesn't work when you're tackling really, really difficult threats. So I've talked a lot about infectious disease threats, but what can we learn from these for the future? I think a first point is that rapid detection is critical because it makes our response much, much simpler. But a strong national or local response is not always enough, and there are times where the global community has to be able to surge. In Ebola, we weren't very coordinated, the governance wasn't there, it was pretty haphazard, and so having better ways for the global community to support national and local responses is key. Some of you are working on antimicrobial resistance. I didn't talk about that today, but for antimicrobial resistance, as well as SARS, as well as Ebola, exquisite infection control is really important, and we have to get better at that, and we have to find ways to elevate the status of that profession. Vector control, I don't even have to say anything about at an institution like this, which is so engaged in that area. But I do want to say, I personally really feel that the pace needed for research has to accelerate. We need the answers quicker because communities are relying on it. And as I mentioned, the community mobilization really shouldn't be an afterthought. It should be your first thought. So you can apply some of these lessons to everything else. You know, good data are essential. Early detection is key. Try to prevent because it's a whole lot easier than responding. And work across sectors. It's great to have met faculty that are working in multiple different disciplines, you know, bringing the biology and economics and agriculture together. The biggest problems out there need multiple sectors. So with that, I am ready for your questions. Thank you.